This is a short talk on the interpretation of panoramic radiographs in the setting of suspected mandibular fracture. At academic centers with oral and maxillofacial surgery departments, it's not uncommon for the panoramic radiograph to be the only study ordered in lieu of a facial CT. Furthermore, even in cases where a facial CT scan is ordered and allows for the diagnosis of a mandibular fracture, the post-operative radiograph is typically a panoramic radiograph. So, learning the appearance of mandibular fractures on this imaging modality is important. This is not going to be a comprehensive review of mandibular trauma, and I'm not going to be discussing the appearance of mandibular fractures on CT. In this lecture, I will review mandibular anatomy and fracture terminology. I will specifically discuss panoramic radiographic anatomy as this requires some familiarity. I will discuss the principles of mandibular fracture treatment and their implications for image interpretation. I will show multiple case examples and then I'll summarize the key points of the lecture. Okay, so let's review some anatomy and also discuss some fracture terminology at the same time. Let's start with the symphysis, which is the anterior mandible in the midline, where the chin would be. The menton or the mental process is right here. You can get symphysis fractures that are truly in the midline, but these are pretty rare. More commonly, you get fractures that are just off of midline, and these are called parasymphysis fractures. The parasymphyseal region actually extends from the symphysis all the way to the mental foramen, which is usually around the second premolar. So any fracture in this region is termed a parasymphyseal fracture. A fracture that occurs posterior or lateral to the mental foramen, but within the tooth-bearing segment of the mandible, is termed a body fracture. So this whole region here is the body of the mandible. A fracture that extends from the most posterior tooth socket to the angle of the mandible is termed an angle fracture. Now the ramus is a little bit confusing because some people will call this going this way the vertical ramus and this part of the mandible going this way the horizontal ramus. Other people just call this area the ramus, and it's assumed that they're talking about the vertical ramus. What makes it even more confusing is that you can get a horizontal fracture of the vertical ramus. You can also get a vertical fracture of the vertical ramus, or some people just call it the ramus. Fortunately, both these fractures are very rare. What is more common is a fracture that people incorrectly call a ramus fracture, and that's this. This is a subcondylar fracture. It extends from the sigmoid notch to the posterior border of the mandible. It's in the subcondylar region, which is really right around here, all this region. And it can extend down here. I mean, if the fracture goes this way, this would still be a subcondylar fracture. That wouldn't be a vertical ramus fracture. It would really have to go from the sigmoid notch all the way pretty much to the angle to call it a vertical ramus fracture. You can also get condylar neck fractures and intracapsular condylar head fractures. All right, so just to round out the anatomy, this concavity between the condyle and the coronoid right here is termed the sigmoid notch. You can get isolated coronoid fractures. These are quite rare. And that pretty much covers the anatomy. Also, I want to point out is the mandibular foramen, where the infravelar nerve enters the mandible and it exits the mental foramen right here. Okay, so that's a good review of mandibular anatomy and fracture terminology at the same time. Okay, so let's see if we can translate the anatomy we just learned to the panoramic radiograph. Obviously, this is not a true depiction of anatomy. This is a somewhat distorted image. It's as if the mandible was flattened out on a single plane. But let me just trace the mandible here and tell you the corresponding anatomy as I go. So I'm tracing the condyle here, posterior border of the mandible, angle of the mandible, the body of the mandible, heading into the parasymphysis, the symphysis. And again, this is probably the mental foramen, and you can kind of see a hint of the infraalveolar nerve canal as well. I'll go to the other side and outline the parasymphysis and body and the angle, condyle, sigmoid notch, coronoid, and the anterior border of the vertical ramus, right there. That's pretty much it. I'd also like to point out this part of the mandible you can call the crest or alveolar crest. And again, many of the fractures extend all the way to this region, so that's a good landmark to know. It's important to understand the principles of mandibular fracture treatment because it'll influence the way you describe the findings and interpret the findings on imaging. So I'd like to start with this concept of occlusal reduction versus anatomic reduction. Elsewhere in the body, when a bone is fractured, the goal is for anatomic reduction, to put the bones back together exactly as they were. It's a little different with mandible fractures, and the goal is actually occlusal reduction. So what do I mean by that? Many times this involves fixation, either temporarily or for weeks at a time to allow the fracture to heal. But if there is a fracture here, say a subcondylar fracture, if you can make sure that the lower teeth align normally with the upper teeth, and you also make sure that the condyle articulates as it should with the glenoid fossa, then even if this alignment isn't perfect, as long as this heals with some sort of osseous union, you're going to be left with the premorbid occlusion and a normal functioning jaw. And that's really all that matters. If you try to get perfect here at the fracture line, if you're even off a millimeter over here, that's a ton when it comes to occlusion. The periodontal ligament is very sensitive, the bite is very sensitive. And again, 1 millimeter of discrepancy here can lead to a larger 3 millimeter discrepancy over here. It can be a really big deal. So the goal is occlusal reduction, not anatomic reduction. That's one of the key points I want to make note of. Well, the second point is that these fractures can be fixed with open reduction or closed reduction. Open reduction involves an incision. It can be an extraoral facial incision or an intraoral mucosal incision with usually either rigid fixation with screws or a combination of plates and screws. Closed treatment is with arch bars and wires, and it involves what's called maxillomandibular fixation. This next topic relates to that because it can determine which type of treatment is needed. You'll read in the literature about favorable versus unfavorable fractures. I'm not sure exactly how important it is, but it's in the literature a lot. Let's take, for example, a fracture that goes this way. We know that the masseter muscle comes down in this direction and inserts on the lower border of the mandible here. And action of this muscle is going to bring this fracture fragment up. which is not a bad thing. It's bringing these fracture fragments together. There are other types of fractures where that wouldn't necessarily be the case. Let's see here. If you did have one of those more rare vertical ramus fractures, you could see how this could lead to sliding of the fragments against each other as opposed to keeping them opposed to one another by the masseter. So I don't think you should ever include the words favorable or unfavorable fracture in your report, but describing the exact orientation of the fracture can help the surgeon figure out whether or not it's a favorable or unfavorable fracture. Okay, this next concept is really important. This will help you not miss fractures. The mandible simulates a bony ring, and so it often fractures in two places, and statistically about 50% of the time it fractures in two different places. Both fractures need to be treated in some way, but they don't need to be treated the same way. One can be treated with closed reduction, one with open reduction, and I'll show an example of that later. Finally, this may be too advanced and maybe I shouldn't even mention it, but it relates to treatment and it does affect how you'll view these images, particularly post-operative images. There is the concept of the need for early mobility of condyle fractures. So if you have a fracture of the neck of the condyle or even subcondyle, the thought is that you don't want to have that condyle not be moving for 6 weeks. So you don't want to put the patient into wire fixation for 6 weeks because it can lead to jaw limited or immobility later on. In intracapsular condylar fractures with intracapsular hemorrhage, the worry is that it could actually lead to bony ankylosis as well. So for subcondylar fractures, condylar neck fractures, or condyle fractures, you want early mobility. So you will often see these fractures treated differently than a fracture here. A lot of times you'll get fractures of two different types at the same time. They may put a plate across this fracture if this fracture is also present. And the reason is that if you don't put a plate here, the way to treat this fracture would be 6 weeks of fixation, but that would be a bad way to treat this fracture. So they'll put a plate on this fracture right here, and that will allow for, let's say, two weeks of fixation, and then they can slowly take the patient out of fixation and allow them to mobilize the joint and prevent ankylosis or limited mobility later on. I'll show an example of this and hopefully it'll make more sense. Now let's do some cases. Case 1. This is a patient who came in post-trauma. What do you see? You probably will see this fracture. It's fairly obvious. It's actually going through the tooth socket, and it actually looks like it's fractured the root of that tooth, which is not common. The teeth don't usually fracture in mandible fractures, but this I would call an angle fracture. And then this is when you really need to challenge yourself to find the second fracture, because again, 50% of the time, the mandible fractures in two places. So you may or may not notice that there is a non-displaced thin fracture right here, extending from the alveolar crest to the inferior border. It's kind of right at the junction of the body and the parasymphysis. But you could imagine how that fracture could easily be missed, but it has to be treated. Case 2. Similar case, actually, really similar case to the last one. This is another patient post-trauma. There is a left mandibular ankle fracture. Again, it fractured the roots of that molar there, that posterior molar. So again, challenge yourself to find the fracture. This one's actually in a very similar location. This one looks a little different because there's some overlap of the fracture fragments, so you get a little bit of a sclerotic appearance here because of the overlap. But you can also see there's a little step off of the inferior border there. I would encourage you as well not just to look at the bone, but look at the teeth, because it really tips you off to where a second fracture might be. Look at the occlusal step off here. That's a pretty big jump, certainly bigger than on the other side. So looking for bony step-offs or occlusal step-offs are really good clues that suggest an additional fracture. Case 3, another patient, post-trauma. There's an obvious fracture here in the right parasymphysis. So where's the second fracture? A little tip is that usually it's the contralateral side. You usually don't get 2 fractures on the same side, although you can. So do you see it? Do you see it? I would say it is here. Do you see that step off? So I actually think there is a subcondylar fracture right here. Let me delete that so you can see it. And if you don't believe me, here's the 3D reconstruction from the patient's facial CT scan. So here's the parasymphysis fracture on the right and the subcondylar fracture on the left. So this is actually a case I saw and treated during my oral surgery intern year. This was a 22-year-old college kid who presented after an altercation with his roommate in which he was punched in the jaw. He complained of pain and malocclusion, and notice on the intraoral radiograph that the posterior teeth are contacting here and here, but the kind of right lateral teeth are wide open. This is abnormal occlusion, and certainly wasn't his occlusion before the event, and this really suggests a fracture. You can also notice a little bit of a step off right between the left lateral incisor and the canine. Shown here is the patient's panoramic radiograph. You may notice that there is a linear lucency running from the alveolar crest between the left mandibular lateral incisor and canine and extends to the inferior border right there. There's some displacement of the proximal fragment superiorly. This is the proximal fragment here. And you can see it's somewhat superiorly displaced. Now, again, challenge yourself to find the second fracture. This one's pretty difficult to see, but just posterior to the third molar, you can see there's kind of a widening of the space, periodontal ligament space posterior to that molar, and you can see there's kind of the hint of a line here, and that's suggestive of a right angle fracture in addition to this left parasymphysis fracture. This patient was treated with closed reduction and maxillomandibular wire fixation. The intraoral photograph here demonstrates the arch bars, the wires, and the improved occlusion. Here is the post-operative radiograph for this patient, and it demonstrates a good occlusion and approximation of the fracture fragments. Note how the right angle fracture is now more apparent without the bony overlap. On all post-operative radiographs for mandibular fractures, it is very important to note the position of the condyles. They should be fully seated within the fossae bilaterally. Because remember, this patient will be wired shut for 6 weeks to allow for healing. If the condyles heal in an abnormal position, this patient would need an open surgery to re-break the jaw and re-establish normal occlusion with the condyle in the right position. So really important to note the position of the condyles on post-operative panoramic radiographs. It's also really important to look for any loose wires. A loose wire may be on the lingual side, which would require actually release of the fixation in order to retrieve. In certain cases, the fixation may be achieved with heavy elastics instead of metal wires, and those will not be visible on radiographs. So this is a new patient. This is a post-operative panoramic radiograph. So what happened to this guy? What's going on? Well, you can see there's a plate at the inferior border of the left hemimandible in the parasympathesis region. There's a maxillary plate, and there's arch bars and wires. So this patient probably had a right hemilefort, probably a left parasympathesis mandible fracture, but there's plates on those fractures. So if they're rigidly fixed with plates, why does the patient still have arch bars and wires? Why are they wired shut? I'll tell you the reason. The reason is this guy. So if this fracture wasn't there, this thin subcondylar fracture, then they would be able to release the fixation. But they have to treat this fracture in some way. You may ask, well, why didn't they just put a plate on that fracture as well? They could have put a plate here. It's very difficult to do intraorally. And you can do it with an extraoral incision and go up this way. But again, there's risks to the facial nerve, there's a scar, there's a host of complications with fixing that fracture with plates and screws. So what they often do is closed reduction for subcondylar fractures. Why couldn't they do closed reduction for everything, you might ask? Well, closed reduction for the Lefort fracture and the mandibular body fracture would be 6 weeks of wire fixation. And I already told you earlier in the lecture, you can't do 6 weeks of wire fixation for a condylar or even subcondylar fracture because of the risk of immobility after 6 weeks of fixation. So here's what they do. They plate the fractures that they can plate. They keep the patient in wire fixation, but not for 6 weeks, because you don't need 6 weeks for the mandible fracture that you plated or the Lefort fracture that you plated. And they'll just do 2 weeks of fixation. And that allows a nice bony callus to form. It allows for some healing to take place. And then they release the fixation, keep the patient on a blenderized diet, and allow them to do stretching exercises for the next few weeks or so. And that will allow everything to heal and will prevent immobility from fixation. So let's just summarize the key points here. Occlusion is key. Again, this is an exception to the rule of anatomic reduction in fracture repair. The idea is occlusal reduction, and if there's some anatomic discrepancy, it's not as big of a deal. As long as the teeth are in their appropriate position with the opposing arch, and as long as the condyles are in the appropriate position within the bilateral temporomandibular joints, and as long as it heals with osseous fusion in between, that's all that matters. Look for the second fracture. It can be subtle, but look for bony or occlusal step-offs as clues to a second fracture. Check the condylar position on post-operative radiographs every time. It's really the main thing that the surgeon is wanting to know. Check for loose wires. Again, it's not insignificant. It can be behind the patient's dental arches, so nobody will be able to see it except for you. So it's important to point out.